Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We also have a Telegram group which you can join for. It is very helpful for accessing all lecture related information. We also have a Google Drive where the PDF of all lectures are uploaded and a master integration key by which you can navigate between the Google Drive as well as the YouTube channel. These are the disclaimers. We are with phase 3, which is recorded pathology lecture. And today we have a very important topic, which is practical approach to diagnosis of salivary gland tumors. And to speak on that, we have Dr. Anila K R. She's MBBS, DCP, DNB pathology. Presently, she's an associate professor in the Department of Pathology at the Regional Cancer Center, Thiruvananthapuram, Kerala. She joined the Department of Pathology in the year 2007 and is continuing as a faculty for the last 16 years. Her areas of interest is oncopathology, head and neck, endocrine pathology. She's also very much involved in teaching MD students and oncopathology fellows. She was awarded the fellowship by the Union for International Cancer Control in the year 2018. She did an observership in head and neck cancer pathology at the famous Mayo Clinic, USA. She's got more than 60 publications in national and international journals. So I would request Dr. Anila to start her talk on a practical approach to diagnosis of salivary gland tumors. Over to you, ma'am. Thank you so much.
Good evening, all. So, today's talk is on a practical approach to diagnosis of salivary gland tumors. At the outset, I would like to tell that this is just an overview of how to approach the diagnosis of salivary gland tumors, and it is not meant to cover individual entities in detail because that is beyond the scope of this talk, and I have used images from the internet. So, what contributes to diagnostic challenge in salivary gland tumors? Why is this such a challenging area? First of all is the rarity. Now, salivary gland tumors, unlike your breast tumors or thyroid tumors, are not common. They are rare. So, the chance that one sees these salivary gland tumors is rare, and that so we are not familiar with seeing salivary gland tumors. That is one of the primary diagnostic challenge. Secondly, the diversity. There are so many salivary gland tumors. The diversity is unparalleled to any other organ system. Then another feature is there is overlapping histomorphology. That also not only within one entity but within different entities also there is overlapping histomorphology. For example, if we take the example of the commonest tumor that we come across, the pleomorphic adenoma, you see that pleomorphic adenoma classically has a chondromyxoid matrix and with epithelial myepithelial cells, and so that in such a scenario the diagnosis is easy. But the same pleomorphic adenoma, when it is highly cellular with scanty matrix, then it becomes a challenge. For example, you can have even a differential of myopithelial carcinoma if it is a myopithelial predominant subtype, then you can have that difficulty. Similarly, the cribriform pattern that is classically you see in adenoid cystic carcinoma, but it is not exclusively seen in adenoid cystic carcinoma. It can be seen in even benign entities like a cellular pleomorphic adenoma, basal cell adenoma, and so forth. So this is another diagnostic challenge. And also the WHO 5th edition has now 21 malignant entities and 15 benign entities. So you can imagine the diverse number of tumors that you come across in salivary gland. So my plan of lecture would be, first we'll briefly touch upon the histology because knowing the histology goes a great way in helping us in narrowing down our differential. And for us pathologists, mostly the first sample that comes from a salivary gland tumor is the FNA from the tumor. And so we'll be briefly going through the Milan system of reporting salivary gland cytology. Then we'll go on to histopathology. What should be the basic approach? And maybe some few common entities we can just touch upon. A brief update from the fifth edition of the WHO regarding the newer entities, and also briefly about the newer IHC and molecular tests that are available. So going on to the histology, you can see like this is the schematic representation of the histology which is widely available in the internet. So this is the serous acini, and serous acini, you have this acinar, the ductal cells, and then you have the abluminal myoepithelial cells. So here you have the ductal or luminal or acinar cells, and you have the abluminal myoepithelial cells. And from there you go on to the intercalated ducts, the small ducts. So here if you see the intercalated duct in detail, that also has a cuboidal lining, and then you have the abluminal myoepithelial cells. After that comes the striated duct. Now why striated? If you see this picture, you know that this basal lamina is thrown into folds here. That contributes to the striations, and so this is the striated duct. And after that, in this picture it is not there, comes the excretory duct, the larger ducts. And here you can see the mucinous acini with the serous demilume. So this is the basic histology. Now this is yet another representation. Here also you can see this acinar, the acinar, the luminal ductal cells, and the abluminal myoepithelial cells, the intercalated duct, here the myoepithelial cells, the striated duct, and the excretory duct, wherein you see multiple cell layer and nuclear stratification. And here it is labeled as myoepithelial cells, and here the abluminal cell is a basal cell. So the basic difference, as you can see from the terminology itself, myoepithelial cell means it has some myocontractile property, and the basal cell doesn't have that property. So when you put an immuno for bringing out or highlighting the myoepithelial bar basal or the abluminal cells, you have to choose a panel which covers the SMA, which includes SMA, P63, S100, because a basal cell may not be positive for SMA, whereas a myoepithelial cell will be positive for SMA. So you can't put just one marker to highlight the abluminal cells, which can be either myoepithelial or basal cell. Also, another IHC I would like to stress upon in this point is the Soxton. Soxton will stain the acinar and the intercalated duct luminal cells, whereas distal to this, Soxton is negative. So translating this schematic representation into what we actually see under the microscope. So here you can see the serous acini, very characteristic because they have this abundant granules, zymogen granules, bluish, deep blue color, large granules in the cytoplasm. Here you see the excretory duct with the stratification, and I don't know whether this can be appreciated under this power. Here you are seeing the striated duct, and here if you see closely you can see the smaller intercalated duct. Now here again the higher power showing these striated cells with these beautiful striations, and here you can see the intercalated duct. So going on to FNAC, which is mostly, in most cases, that is the first line of approach, because if suppose the tumor is intraoral from the minor salivary gland, maybe due to difficulty of doing the FNAC, you may be getting a biopsy. Otherwise, in major salivary gland tumor like your parotid, submandibular and all, the first sample that a pathologist comes across is FNA from the tumor. Of course, like in any other scenario, we have to have a clinical and radiological details with us. And that is most times we have to reach out to the clinicians for the details. And if luckily you are doing the FNAC yourself, try to get as much information from the patient. You can use a 23 or 25 gauge needle, and you can use aspiration or non-aspiration technique depending upon your expertise and your comfort level. And regarding cystic swellings, like sometimes the swelling is fully cystic, like a Warthin's tumor, wherein you get bilateral cystic swelling. In a classical scenario, in a smoker, bilateral cystic swelling is the classical presentation of Warthin's tumor. For that matter, any cystic swelling, you have to aspirate and get the whole cyst fluid, and then you have to re-aspirate from any remaining swelling, and the cyst fluid should not be discarded, and it can be used for cell block, and it may give important information. And factors what are determining the diagnostic efficacy in FNA is right from the basic step of how well versed you are in that technique of doing FNA, your sample collection, the smearing, the transfer to the fixative, everything matters. And especially with regards to salivary gland FNA, it is advisable that you always do both the Pap stain and the MGG stain. The Pap stain because it brings out the cellular details, whereas in salivary gland tumors, the quality, the type of matrix is highly important in your differential, and that is more brought out, highlighted in the MGG stain. So what are the clinical details? So the site matters, the size of the lesion matters, what is the duration? Is there any rapid increase in size? Is there any associated pain? Because if it is associated with pain, there is a chance of nerve involvement which will point towards a malignant entity. Radiological details are important, and you should get as much information as possible. For example, sometimes a parotid swelling, the radiologist may be able to tell you it is not actually a salivary gland tumor, but it's an intraparotid lymph node. So, such subtle details are quite important. So this is just a schematic representation of the aspiration and non-aspiration technique of doing the FNA. In the aspiration technique, you are giving negative pressure by using the syringe. An advantage is that you may get more material, but the disadvantage is that the material can escape into the hub of the needle. Then it becomes difficult to retrieve the material. In non-aspiration technique, an advantage is that you can, with the other hand, fix the swelling, and you can get a feel of the swelling while aspirating. So whichever technique you are comfortable, you can proceed. And the cell block techniques, there are different methods of cell block, and the advantage of cell block is that you get a tissue for doing ancillary techniques like immunohistochemistry, so that you can give more information in cytology itself, and better architecture appreciation also can be done. So you have more tissue for doing ancillary techniques. So this is the importance of doing an MGG and Pap stain. This is a classical case of pleomorphic adenoma. You can see that in the Pap stain also we are seeing matrix, but how beautifully this is brought out in the MGG stain, whether that feathery quality with the cells embedded within the fibrillary matrix, that is more classically brought out with the MGG stain. Especially so if you are coming across a tumor with scanty matrix in the Pap stain, you may not be able to pick up that. But how this MGG stain, it is so colorful that it gets highlighted. So the importance of doing both the stain in salivary gland tumors. So briefly about the Milan system, as we all know, there are 6 categories in the Milan system, and like varying the different systems, the Bethesda of the thyroid and all, what are the advantages that across the world there is a uniform language for reporting so that the clinicians can interpret according to which category you are putting the lesion, and they can plan the management, and also they get an idea about the risk of malignancy. So this is the Milan system. You have non-diagnostic, non-neoplastic, atypia of undetermined significance. Under neoplasm, you have benign neoplasm where you can categorically say that this is a benign tumor. For example, you have pleomorphic adenoma, Warthin's, etc. And then comes this challenging group of salivary gland neoplasm of uncertain malignant potential. Then you have suspicious for malignancy and malignant. So you can see that when it is benign, the risk of malignancy is just 5%, whereas when you give a diagnosis of non-neoplastic, the risk is even more, like 10%. And you have clear-cut directions on what you can do with the patient. So non-diagnostic means it is limited by material. It can be due to staining issues. It can be due to obscured cells due to a lot of blood in your smear and so forth. And there can be also non-diagnostic because there can be a clinical, radiological or pathology discordances there. And you may sometimes have a scenario where there is hypertrophy of the salivary gland tissue. So normal salivary gland tissue presenting as a clinical mass. Non-mucinous cyst fluid. Remember, mucinous cyst fluid is not a non-diagnostic criteria. Only if it is non-mucinous cyst fluid, it is non-diagnostic. So in all these scenarios, you can repeat the procedure with the rapid on-site evaluation to ensure that at the repeat at least you have got sufficient material for diagnosis. Mind you, the mucinous material only. You have to be very cautious when you are interpreting an FNA containing mucinous material because in a low-grade mucoepidermoid, the cells can be quite scanty. So you have to correlate clinically, radiologically, and then word your report accordingly. Matrix alone also doesn't make it a non-diagnostic because chondromyxoid matrix in a pleomorphic adenoma, sometimes when you aspirate, that is the only material that you get. Abundant inflammatory cells is again not non-diagnostic. Scanty atypical cells. However scanty, if the smear contains atypical cells, it is not a non-diagnostic category. So non-neoplastic. Now non-neoplastic is basically due to the inflammatory conditions. It can be due to ciliadenosis, oncocytosis, and sometimes what the clinician feels like a salivary gland tumor on aspiration may turn out to be just a reactive lymph nodes. So this is where there is an inflammatory pathology with mainly the ductal cells and background showing dense inflammation. Atypia of undetermined significance can be a reactive atypia due to metaplasia, mucinous material, and with low cellularity, it can be lymphoid lesions. So herein you see few atypical epithelial cells with oncocytic features. You can't categorize it. You can't definitely say it is a neoplasm or not, and you put it under this category. Now going to neoplasm, benign neoplasms like pleomorphic adenoma, Warthin tumor, oncocytoma, usually you can give a clear diagnosis in FNAC. So this is a classical case of pleomorphic adenoma with that fibrillary matrix wherein cells are embedded within the matrix. This is the MGG of the same, and you sometimes call it the troll hair, like this color, this feathery, fibrillary nature is characteristic of pleomorphic adenoma, wherein the cells are embedded within the fibrillary matrix. A Warthin's tumor with the oncocytic cells in a dirty background showing lymphocytes. Oncocytoma, So now salivary gland neoplasm of uncertain malignant potential. This is a highly challenging area in FNA. Here we know that it is a neoplasm, but you can't categorize it into any specific entity. And usually these uh, cases that fall into this category are either benign neoplasms which are highly cellular or a low grade carcinoma. So these usually come under this category. Now, what can be the basic approach to this category? So it is a cellular neoplasm. Always try to exclude whether it is a pleomorphic adenoma or a Warthin tumor. A cellular Warthin tumor is actually rare because usually it is cystic with the cystic fluid, dirty background with this oncocytes. Um, and usually you can exclude these two. Then see the smear what is the dominant cell type and is there any atypia. Now the cells can be maybe just monomorphic, the cells all having similar appearance, and these monomorphic cells, try to see whether it is basaloid cells that you are seeing, oncocytic cells or clear cells. And if it is pleomorphic, if the cells that you are seeing is pleomorphic, then you can't put this that particular case into a sump. Now these are the differential of basaloid sump. It is a highly challenging area. So basaloid sump, you can see it runs across benign entities like pleomorphic adenoma to the adenoid cystic carcinoma. So in between you have basal cell adenoma, basal cell adenocarcinoma, myoepithelioma, myoepithelial carcinoma, epithelial myoepithelial carcinoma. See, these are differentials which are even challenging in histopathology. So you can imagine the difficulty to categorize these lesions correctly in FNA unless if it is a classical morphology. So these are examples of some basaloid looking cells. We can't actually categorize them into any definite entity. So in this scenario, the type of matrix can give a clue. Fibrillary versus non-fibrillary can refine the differential. For example, a fibrillary is rather you are like not that anxious, because a non-fibrillary hyaline matrix points the direction towards a malignancy like an adenoid cystic carcinoma, whereas fibrillary matrix points it towards a more cellular benign neoplasm like your pleomorphic adenoma. And basaloid sump with non-fibrillary matrix hence carries a higher risk of malignancy and try to exclude adenoid cystic carcinoma, although it may not be easy always. Differential of oncocytic sum can range from Warthin tumor oncocytoma to malignant entities like mucoepidermoid carcinoma, the oncocytic variant, acinic cell carcinoma, secretory carcinoma, and salivary duct carcinoma. So that is sheets of oncocytic cells. Then the clear cell sump. It is cellular with clear, foamy, granular or vacuolated cytoplasm, and nuclear cytology grade is low to moderate. See, there is absence of high grade features, because if we get high grade features, then that lesion doesn't fall under sump. So this is an example of how a clear cell sump looks like. Now suspicious for malignancy. So at least you have a suggestion that it could be malignant, but all the criteria for a specific diagnosis is not present. So you have to specify whether you are suspecting a primary salivary gland malignancy. Sometimes you may be suspecting a metastasis or a hematolymphoid malignancy. So that should be clearly mentioned in your report. What is your suspicion regarding the type of malignancy? So this is an example. The cells are definitely atypical, but you can't categorize them into a definite category. Now, malignant. So you have a combination of cytomorphologic features that either alone or in combination with ancillary studies is diagnostic of malignancy. When possible, an attempt should be made to provide the grade of the neoplasm as well as the specific tumor type. For example, if it is a mucoepidermoid, you can try to grade the tumor, whether it is low or a high grade that you are suspecting. So these are some classical cytology smears, like this is an actinic cell carcinoma with this formy cytoplasm quite resembling the normal acinar cells. This is an adenoid cystic carcinoma. Now the adenoid cystic carcinoma, the matrix, the hyaline matrix is quite different from that you come across in a pleomorphic adenoma. Here, as you can see, these are rounded, definite. There's no fibrillary quality to it, and the cells also are not very merging with the hyaline matrix. They maintain their own space and are actually separate from the matrix. Unlike pleomorphic adenoma, where you see the cells embedded within the matrix. So, and again, this adenoid cystic carcinoma. This is a mucoepidermoid carcinoma where you can see this mucoid cells and the other epithelial cells. Secretory carcinoma with a vacuolated cytoplasm. Now, in FNA, what does your surgeon require from the report? What all information can you give to help the surgeons in making a decision? First of all, you can give the information if it is salivary or non-salivary, because every other lesion that the surgeon refers to us for an FNA as salivary gland tumor need not be a salivary gland tumor. It can very well be a lymph node, a reactive lymph node. And so that can first be clarified. And if it is salivary, whether it is neoplastic or non-neoplastic, and if it is neoplastic, whether it is benign or malignant, and if malignant, if possible, the grade, because depending on the grade, if it is a low grade, you can do a more restrictive surgery, and if it is a higher grade, more radical procedures may be needed. And if possible, always try to diagnose an adenoid cystic carcinoma, because these tumors needs always a radical surgery, because it is very difficult to get a clear margin in surgery, and many a times you need frozen section, and even in frozen section, though grossly you may not see the tumor microscopically, it highly likely to see the tumor going on to the margin. So resections are difficult. Like clear margins in case of adenoid cystic carcinoma are difficult, and so the surgeon can plan accordingly. So that is the importance of giving a diagnosis of adenoid cystic carcinoma in the FNA. So now going to histopathology. So in histopathology, what should be the basic approach? So what matters is whether the anatomic site is important. So is it a parotid tumor, submandibular, like a major salivary gland, or is it intraoral, like a minor salivary gland tumor, like your floor of mouth, palate, base of tongue, buccal mucosa, and so forth. So what is the importance is that many a times the major salivary gland tumors are usually benign, though it can also happen, but minor salivary gland, it is mostly malignant. So when you sign out a report of a benign salivary gland in a minor salivary gland area, you should be very careful, because it is highly there is more chance of malignancy in a minor salivary gland. And also the clinical picture, sometimes intraoral lesion, it may be submucosal. A submucosal lesion should direct your attention to a salivary gland tumor, unlike an epithelial squamous cell carcinoma and all, which is usually ulcerated, indurated with mucosal involvement. Unlike that, a salivary gland tumor, basically the minor salivary gland tumor intraorally, usually has a bulging mucosa with submucosal tumor. Grossly, now once you get your specimen, you can look for more details like the circumscription, whether it is solid cystic, whether you are seeing an infiltrative border, and so forth. And under microscopy, you can look for what is the cytomorphology of cells. Is it acinar, ductal, myoepithelial, is it basaloid looking, and so forth. And one other important thing which helps to narrow down your differential is phase. What was the phase of the tumor? Meaning, what are the types of cells? Is it a tumor having only one type of cell, or is it having like two biphasic or two cell types, the luminal and abluminal cells, or triphasic means three different types of cells or more. So what is the different types of cells constituting the tumor also influence your differential. So anatomic site, as I mentioned earlier, 80% of salivary gland tumors are seen in the major salivary glands, that is parotid and submandibular glands. Among the minor salivary glands, the most common site is a palate with 55%. And as I mentioned earlier, the major salivary glands, 80% of them are benign, whereas minor salivary glands, 50% are usually malignant. So the smaller the involved salivary gland, the higher the possibility of the tumor being malignant. Now, certain salivary gland tumors have preference for certain sites. For example, the polymorphous adenocarcinoma. It is usually seen in the minor salivary gland, intraorally, the base of tongue, palate, floor of mouth, and so forth. So when you get a case in a major salivary gland like a parotid, if you diagnose polymorphous adenoma, be careful because it is highly unlikely that a polymorphous adenocarcinoma comes in a major salivary gland. But we know that any tumor can occur anywhere, so there is no exception, but usual pattern is like this. The polymorphous adenocarcinoma is mostly seen in the minor salivary gland intraorally. Also, clear cell carcinoma is another tumor which is mostly seen in the minor salivary gland. Canalicular adenoma. So, as I have been mentioning, the minor salivary gland tumors are more the chance of getting malignant salivary gland tumors, but an exception is the canalicular adenoma. So, this is a benign tumor seen in the minor salivary gland of the upper lip. Adenoid cystic carcinoma. So some salivary gland carcinomas can occur both in the major and minor salivary gland, and one such entity is the adenoid cystic carcinoma. So grossly, what all will you look for? You can look for the relationship with surrounding structures, whereas it is encapsulation, circumscription, is there infiltration, necrosis. So that you can look for, and this is a classical case of pleomorphic adenoma, which is quite circumscribed, and I don't know whether you can appreciate that chondromyxoid looking areas in the gross. Now, cell morphology. So we have in the initial part of the talk, we have gone through the basic histomorphology. So this is a normal histology, and you see these acinic cells, and here is the acinic cell carcinoma, very close resemblance. So that when you see under the microscope, what is the tumor resembling? The normal structures, what is it resembling? Extrapolating that will be of use. So here you see the adenoid cystic carcinoma, and here you see the intercalated duct from here, and the close resemblance to the intercalated duct with the biphasic lining. This is the striated duct, and this is the Wathin's tumor. You can just see the close resemblance. This excretory duct. From there, usually you get high-grade tumors like your salivary duct carcinoma. So I have earlier mentioned about the face, that is monophasic, biphasic, and triphasic. So when you get a monophasic carcinoma, it is usually a carcinoma or benign. It is myoepithelium or myoepithelial carcinoma. Biphasic, you have a whole lot like a basal cell adenoma, basal cell adenocarcinoma, adenoid cystic carcinoma, epithelial myoepithelial carcinoma, and triphasic you have the mucoepidermoid carcinoma with the mucous cells, epidermoid cells, and intermediate cells. So this is an example of a monophasic myoepithelial carcinoma. Of course, you have to have the immunostains to substantiate that it is a single cell population. And here we have put the S101 marker, which is showing this positivity. And this is epithelial. And as I mentioned, it is not a single marker. Usually you have to put a panel of myoepithelial markers. Now this is a epithelial myoepithelial carcinoma. I don't know in this image how much you can appreciate. So this is the ductal or epithelial cells, and here the clear cytoplasm, what you see here is the myoepithelial cells. In this you may be better able to appreciate. So here then the cuboidal cells with the hypochromatic nucleus, and here you see cells with abundant clear cytoplasm, the abluminal myoepithelial cells. And mind you, myoepithelial cells can have a whole lot of different morphology. Like you can have polygonal, you can have spindle shaped, and so forth. So this is the same case showing the CK7 positivity in the luminal ductal cells, and this is the abluminal S100 positivity. S100 is a good myoepithelial marker. Now mucoepidermoid carcinoma showing the mucous cells, the epidermoid cells very clear with the clear cytoplasm and the intermediate cells. Next, in histomorphology, in histology, that helps you to reach a diagnosis is the patterns, but patterns can always be overlapping. And cribriform pattern, the comido pattern of necrosis, which is classically seen in salivary duct carcinomas, the nodular pattern. Then you can go on to the nature of the stroma or the matrix, and myoepithelial cells are known to produce the stroma or matrix. So you can when stroma or matrix is present, you can push a differential towards the direction of a myoepithelial component being present in that, or abluminal cell being present in that tumor. You have to use immunostains judiciously, and there are some specific markers and there are some markers which are not that specific, and also you have the molecular test now. Now the patterns, as I mentioned earlier, cribriform pattern, this islands of cells with nice punched out lumina containing that hyaline matrix, and this basaloid cells. This is very classical of a adenoid cystic carcinoma, but as I mentioned in the early part of the lecture, it can be seen in cellular like basal cell adenoma and even in pleomorphic adenoma. So this is a salivary duct carcinoma, like in your breast carcinoma, where you see this nest of cells with a central comido pattern of necrosis, a high-grade tumor. Now, the difference in stroma, this we have discussed in while we were discussing the FNA. So this is the chondromyxoid matrix, the fibrillar matrix that you see in the pleomorphic adenoma, and this is a hyaline matrix that you see in a adenoid cystic carcinoma. Now, immunohistochemistry. So we have for immunostains for the luminal or epithelial cells, we have CK7 EMA. For myoepithelial and basal cells, we have abluminal cells, we have P63 SMA S100. For salivary duct carcinoma, we have CK7, androgen receptor, HER2/neu, and the androgen receptor positivity and HER2/neu positivity has therapeutic implications also. For secretory carcinoma, we used to have mamma globin S100, and now we have a new nuclear marker, pan-TRK, which corresponds to actually the molecular alteration which occurs in secretory carcinoma, ETV6 NTRK. So this is a highly specific marker with around 90 to 100% specificity. But pan-TRK is also known to be positive in some unrelated tumors, like tumors not related to the salivary gland, like the infantile fibrosarcoma, congenital mesoblastic nephroma, and so forth. So, a salivary gland tumor pan-TRK positivity has high specificity for secretory carcinoma diagnosis. Adenoid cystic carcinoma, we used to have c-KIT, which is positive in the ductal cells, which is not that specific a marker. Epithelial myoepithelial markers, of course, highlights the biphasic nature of the carcinoma. Then we have the MYB. So MYB corresponds to the molecular alteration happening in adenoid cystic carcinoma due to the translocation resulting in MYB NFIB fusion. But this IHC unfortunately is not that specific, though it is highly sensitive. The specificity is actually around just 50-54 percentage, and so in difficult cases and when it is inconclusive, we may have to resort to molecular tests for confirming the adenoid cystic carcinoma. Actinic cell carcinoma, the IHC stains which were available were DOG1, SOX10, and now we have a highly specific marker NR4A3. Now, this NR4A3 specificity is about 90 percentage, but it can be positive in a small proportion of carcinomas like the secretory carcinoma and polymorphous adenocarcinoma. Now going to the normal histology, in this you can see this as this is the SMA IHC, and you can see that the abluminal cells are highlighted by the SMA. This is the P63, the nuclear P63 positivity in the basal bar bioepithelial cells, and this is the DOG1 positivity I just mentioned, the apical membrane positivity. This is the normal salivary gland histology wherein these IHCs are highlighting the normal acini. This is the CK7. This is the biphasic tumor showing the luminal ductal cell positivity of CK7, whereas the abluminal cells are negative. This is the actinic cell carcinoma showing diffuse strong nuclear positivity for NR4A3. So this is the mammaglobin positivity in the secretory carcinoma, and herein you see the pan-TRK nuclear positivity. So this shows the diffuse strong nuclear positivity of MYB in adenoid cystic carcinoma. The salivary duct carcinoma with the androgen receptor positivity, which is useful in the treatment also, in deciding on treatment also. PLAG1, as we all know, is a marker for pleomorphic adenoma. Another important marker that is highly useful is the, and coming up marker is the LEF1, that is lymphoid enhancer binding factor 1, because basaloid salivary gland neoplasms are a diagnostic challenge, and this helps in diagnosing this basaloid salivary gland neoplasms, because this marker is positive in benign basaloid salivary gland neoplasms. So this is a basal cell adenoma, a cellular basal cell adenoma. You can know how difficult it may be to differentiate from an adenoid cystic carcinoma, the solid pattern and all. But here the LEF1 is of help, that it is nicely showing nuclear positivity. Now grading, basically the grading of salivary gland tumors, when you make a diagnosis of a specific carcinoma, that itself carries a grade attached to it. For example, actinic cell carcinomas are generally considered to be low grade. Your polymorphous adenocarcinoma, secretory, basal cell, hyalynizing clear cells. So there are a whole lot of carcinomas inherently known to be low grade. Also, there are intermediate malignant like your myoepithelial carcinoma, sebaceous adenocarcinoma, lymphoepithelial carcinoma, and high-grade tumors are your salivary duct carcinoma, squamous cell carcinoma, small cell, all your neuroendocrine carcinoma, small cell, large cell, neuroendocrine carcinomas, carcinosarcomas. Now, there are certain carcinomas which are of variable grade, and there you have to grade the tumor based on histomorphology. So, you have a mucoepidermoid carcinoma, which can be either low, intermediate, or high grade. You can have adenoid cystic carcinoma grade 1, 2, and 3. Salivary carcinoma NOS also you can grade based on histomorphologic features, and so forth. So mucoepidermoid carcinoma, you have a number of grading systems for mucoepidermoid carcinoma, but the basic feature that you look for is the um, solid bar cystic. The more the solid, higher the grade of mucoepidermoid carcinoma, and the more cystic, the lower the grade of mucoepidermoid carcinoma. Other features like necrosis, mitotic figures, lymphovascular invasion, perineural invasion are other features, and these different scores are given by these different grading systems based on which you grade your mucoepidermoid carcinoma. Adenoid cystic carcinoma, you have a, when the main pattern is tubular, it is low grade. A cribriform pattern makes it an intermediate grade, whereas a solid, if you have more than 30% solid areas, then it is a high grade adenoid cystic carcinoma. Adenocarcinoma NOS, or the now recently renamed as salivary carcinoma NOS, also you can grade based on the various histomorphological features. Now, a word about high grade transformation. Now, any of the previously mentioned tumors like your acinic cell, which is generally considered to be a low grade, the polymorphous adenocarcinoma, again a low grade, all these tumors and also the higher grade tumors like the adenoid cystic, all of them have the potential to undergo high grade transformation, wherein you see the classical area and then you come across an area of increased cellularity, necrosis, and mitotic activity. Now, briefly about what are the updates, what are the new entities that have come across, that we come across in salivary gland tumors in the WHO 5th edition. So you have this 4 benign newer entities. One is your sclerosing polycystic adenoma, which was previously mentioned in non-neoplastic sclerosing polycystic adenosis. Now it has been shifted to the benign neoplastic category. Sclerosing polycystic adenoma. Then you have keratocystoma, intercalated duct adenoma, and striated duct adenoma. So this is the change. You have sclerosing polycystic adenosis shifted to sclerosing polycystic adenoma. You have intercalated duct hyperplasia shifted into the benign epithelial tumor, intercalated duct adenoma and hyperplasia. And you have canalicular adenoma and other ductal adenoma, which was classified as benign tumors. Again, here we have separated it out into canalicular adenoma and striated duct adenoma. So this is how your canalicular duct adenoma looks like. And the here you have striated duct adenoma. And here you have the SMA cells where it is not seen around all of the ducts. Here scanty SMA positive myepithelial cells. Keratocystoma is characterized by squamous epithelium lined cysts containing this lamellated keratin. And sclerosing polycystic adenoma. This has been shifted into the neoplastic category because of identification of characteristic molecular alterations. Based on that only this has been shifted. And the implication of shifting it into the benign category is that since it is a neoplasm, we pathologists have to mention about the status of margins in an excision specimen, and very rarely carcinomas have been mentioned to be arising from this entity. And the characteristic feature is in these acini, instead of that cymogen granules, here it is bright red or eosinophilic granules that you are seeing in the acini. Also, you see these dilated ducts and periductal hyalinization. These are the characteristic features. So newer malignant entities, you have actually three newer entities: microsecretory carcinoma, sclerosing microcystic carcinoma, mucinous adenocarcinoma. And then the previous adenocarcinoma, NOS, oncocytic carcinoma and all have been merged together under this salivary carcinoma, NOS and emerging entities. So these are the changes. So now you don't have adenocarcinoma NOS, adenocarcinoma NOS, poorly differentiated carcinoma and oncocytocarcinoma together comes under this new category of salivary carcinoma NOS and emerging entities. And you have these three newer entities: microsecretory adenocarcinoma, mucinous adenocarcinoma, and sclerosing microcystic adenocarcinoma. So this is a microsecretory carcinoma wherein you see these small dilated ducts like containing this material, and you can this can resemble an adenoid cystic carcinoma, but this is a monophasic tumor wherein you see just a single population of cells lining the ducts, and uh, also, it may also mimic a secretory carcinoma, but fortunately, this tumor is negative for mammaglobulin. Then here, this microsecretory, it is positive for P63, S100, and SOX10. Sclerosing microcystic adenocarcinoma, you see this abundant sclerosis in a hyalinized stroma, and this is actually a biphasic tumor, and the sclerosis and hyalinization, it can mimic because of that hyalinizing clear cell carcinoma, but this tumor, unlike a clear cell carcinoma, is biphasic. And mucinous adenocarcinoma. So now you have a primary mucinous adenocarcinoma of the salivary gland, and with the characteristic molecular alteration. And this is helpful because otherwise you would have to rule out a lot of cases of metastasis. You may have to give consideration of metastasis of a mucinous carcinoma from elsewhere to the salivary gland. But with this entity, you have a characteristic molecular alteration, and if you pick that up, you can be sure that it is a primary mucinous adenocarcinoma of the salivary gland. So with that, coming to what is the role of molecular alterations. So there are different purposes of molecular alterations that we pick up in salivary gland tumors. It has helped us to recategorize entities. So as I mentioned earlier, now sclerosing polycystic adenosis of the previous WHO edition is now sclerosing polycystic adenoma. This has been included as a tumor or a neoplasm because of this identification of this alteration. So PI3K, PT and AKT alterations have been picked up in this entity. Another is molecular alterations can justify placement of an entity. So cyaladenoma papilliferum is classified as a benign neoplasm, and we can justify that because cyaladenoma papilliferum has been known to have this BRAF PV600E mutation. So in the spectrum of papillomas in the salivary gland, you have cyaladenoma papilliferum, intraductal papilloma, and inverted duct papilloma. And cyaladenoma papilliferum, unlike the other two entities, have been known to be associated with more recurrence, and it justifies its placement in this benign neoplastic category. Now, molecular alterations have helped us to define new entities. For example, the new carcinoma that we have incorporated in the WHO 5th edition, the microsecretory adenocarcinoma is seen to be associated with the MEF2C SS18 fusion. So also molecular alterations can help reinstate entities. So a mucinous adenocarcinoma, the primary mucinous adenocarcinoma of salivary gland has the AKT1PE17K mutation. So if you have this mutation, you can be sure that this is unlikely to be a metastasis from elsewhere, and it is likely to be a primary mucinous adenocarcinoma of the salivary gland. So it helps you to avoid unnecessary investigation for the patient, to rule out an extensive search for a primary elsewhere. Molecular alterations can confirm or expand the spectrum of subtypes. For example, mucoepidermoid carcinoma has a whole lot of subtype like the clear cell subtype, oncocytic subtype, which is a problem, which has we may even have a differential of a benign tumor like Warthin tumor for the oncocytic subtype of mucoepidermoid carcinoma. And in such difficult scenario, demonstration of CRT-C1-MAML2 or the CRT-C3-MAML2 translocation help to confirm that it is a mucoepidermoid carcinoma that we are dealing with. Next is molecular alterations can help form a continuum across the entities like intraductal carcinomas. So intraductal carcinomas, you have different subtypes like the intercalated type, the oncocytic type, the apocrine type. So all these different subtypes can be grouped under the common umbrella term of intraductal carcinoma because it is shown that these fusions are shared or overlapped within these subtypes. So NCOE4 RET fusion and TRIM27 RET fusions. Now, apart from all these diagnostic uh, helpfulness in diagnosis and categorization of tumors, another important role played by molecular alterations is that they have a role in deciding the therapy. So secretory carcinoma, if you now have the option of treating secretory carcinoma with tropomyosin receptor kinase inhibitors. Now, only if that TRK mutation is there, this is useful because secretory carcinoma can sometimes show other types of mutations also. So, knowing that this a particular secretory carcinoma harbors the mutation, then only that TRK inhibitors is useful in that therapy. If it is having other mutations like the RET, MET and so forth, which occurs in a minority of tumors, this therapy will not work for such patients. Adenoid cystic carcinoma, we know that the mutation, the MIB mutation, NFIB MIB mutation is a characteristic of adenoid cystic carcinoma, and you have an IHC and FISH test for demonstrating that. But that is not of therapeutic use, but another molecular alteration, that is the downstream inhibition of IGF-1R AKT signaling, has been shown to be of therapeutic use in adenoid cystic carcinoma. And we all know that salivary duct carcinoma, the androgen receptor and HER2 new positivity, that will decide on the treatment given for recurrences in case of salivary duct carcinoma. So secretory carcinoma usually harbors this translocation 1215, and the resulting gene fusion is ETV6 NTRK3. Adenoid cystic carcinoma, the translocation leads to MYB NFIB fusion. Pleomorphic adenoma, the PLAG1, mucoepidermoid carcinoma, CRTC1 MAML2, that is mostly seen, also is seen CRTC3 MAML2. Clear cell carcinoma, hyalinizing clear cell carcinoma is characterized by EWSR1 ATF1. And this is the cytogenetics of secretory carcinoma, and this is from shared by Dr. Garcia from Mayo Clinic. Now we'll wind up this lecture with a case. A 54-year-old lady who presented with a mass in the soft palate and excision of mass was done. So this is the image from the slide. So at this power, you can see that the neoplasm, it is a cellular neoplasm which is infiltrating, and you have nests of these cells, and under this spur you may be able to say, because the cells are having eosinophilic cytoplasm, and the nucleus fairly monomorphic, I would say, and a little bit of clear ring of the cytoplasm here and there. This is a higher power view. In this image, what is characteristic is the hyalinization. Okay, hyalinization. You can see the morphology of cells better, fairly monomorphic, and infiltrating, right? So sheaths, cords, nest, trabeculae, monotonous, polygonal to round epithelial cells, variably clear bar eosinophilic cytoplasm. I would say rather more of eosinophilic cytoplasm and hyalinization. So as we have seen throughout this lecture, it is a minor salivary gland tumor, the palatal tumor, and it is having infiltrative growth. It is a monophasic tumor and with hyalinization. So it is a our direction should be towards a low-grade salivary gland carcinoma that we are dealing with, and accordingly, uh, based on the differential of hyalinizing clear cell carcinoma, positivity for special strains is PAs diastase, musicarmin. Mind you, musicarmin can be positive because few cells in a clear cell carcinoma can be positive for mucin, and therein you may have a differential of mucoepidermoid carcinoma, but mind you, mucoepidermoid carcinoma is a triphasic tumor. It is not a monophasic tumor like in this particular case. We were seeing just one type of cell, and it is also, it is what we were seeing is a low grade tumor. The cells were pretty monotonous. IHC positive for CK, P63, P40. IHC is negative for S100 protein and SMA, because another differential in this scenario would have been a myoepithelial carcinoma. So this helps to rule out a myoepithelial carcinoma, and the characteristic molecular finding would be a EWSR1 ATF1 fusion in fish. So this is a case of hyalinizing clear cell carcinoma. So musicarmin can be positive, mind you, and this is a P63 diffuse nuclear positivity. And the take-home message would be the approach to salivary gland tumors, like every other system in pathology, should be a multidisciplinary approach. You should have close discussions with your clinicians, radiologists. There should be awareness of the basic histology. FNAC is the first line in salivary gland tumors. The technical and interpretation expertise matters. How much information you can give to your surgeon. You have to categorize into benign and malignant. Malignant tumors give the grade. In case of malignant tumors, if it is an adenoid cystic carcinoma, try not to miss that diagnosis because it is of great importance in planning the surgery and maybe giving an intraoperative frozen consultation for margin status. You have to have a judicious use of IHC. There are IHCs newly available. Some are specific, some are not specific. So you have to be careful. And molecular tests may not be available each and every center. Maybe you have to outsource only if that matters to the patient, like for treatment purposes, and when the diagnosis is of that categorization is of that much importance. So you have to be aware of the newer tests available. So lastly, I would like to thank Regional Cancer Center, particularly the patients of Regional Cancer Center, because from each day from their material, I learned something new. So I'm deeply grateful to the patients of RCC. Uh, and also, lastly but not the least, also to Mayo Clinic, and particularly Dr. Garcia, under whom I was able to do an observership at Mayo Clinic, which has greatly enriched my approach to the diagnosis of these rare tumors. So thank you all.